We're going to be talking about working with family caregivers as people transition from hospital to home and how different challenges to that. So Mary Ann Sterling, who currently works with the NIH but has a lot of personal experience working with two parents and a parent-in-law who've had Alzheimer's. So she's going to bring that perspective. Then Danny Van Leeuwen, who is a nurse, an informaticist, wears a lot of different health hats, is also a patient and a family caregiver, is going to add to that perspective. And then I'm Geri Baumblatt, so my background is in, this keeps falling, multimedia and interactive patient engagement. So I'm going to talk about some of the challenges that we need to think about when we're designing tools for family caregivers in this situation, and then some of the a little survey of some of the tools that are emerging for this. And then from there, Cathi Crookston, who is also a nurse and VP of Sales at Wolters Kluwer, which recently acquired Emmy, is going to talk about the Emmy transition product and how that's been designed to kind of help reach out to family caregivers as well. I don't think I can stabilize this. Maybe that's better. Okay, so and then, as we mentioned, many of us are wearing these walking gallery jackets. So that is our patient and or family caregiver stories. So they're meant to not be obvious as to what they mean. So the idea is, this is an artist, Regina Holiday, and she herself is a very fierce patient advocate. And so she thought this was real estate that was not being used at conferences. And so you send her your patient or family caregiver story, and you send her a jacket, and then she interprets it and paints it on the back. And the whole idea is you wear it to conferences and events, and then people say, what is that thing on the back of your jacket? And it's an opportunity to tell that story. So that's what those are, and pretty much anybody can participate. There's now how many hundreds? Over 500 walking gallery jackets. And the other thing that is great about it is if you go to a random conference or event and you see somebody wearing one, you can just walk up to them and start talking to them because you know they're like in this same weird walking gallery world that you're in. Okay, so we're going to get started, and Mary Ann Sterling is going to kick things off talking.
No, we got two things to.
Oh, do we?
Yeah.
Oh.
No worries, I got it.
Oh, okay. Perfect. Go for it. I'm going to sneak behind you.
Absolutely. And folks, just another note on the walking gallery. In my Mary Poppins bag over there in the corner, I actually have some brochures so you can get to know Regina, the walking gallery, and send your business jacket to Regina to have your story painted on the back. So check with me afterwards. I have a couple brochures in my Mary Poppins bag. All right, let me start with reading glasses, as so many of us have to start with these days. All right, so I'm actually going to lay the foundation for today's discussion through the lens of elder care transitions, as so many of us adult daughters have to do now. As you can see here on my slide, I liken them to the sinking of the Titanic. It's all the hidden stuff under the surface that makes this a disaster every time. I'm sure a lot of you in here feel that pain. All right, in the fall of 2015, my mom fell for the seventh and final time. We endured 7 care transitions in just over 4.5 months. The lack of communication between healthcare providers was stunning. I actually became my mom's electronic health record and medication list and the project manager of her care transitions. All right, so like everything else in healthcare, we need to establish a common definition. I like doing that. That said, a transition of care can happen between any of the entities that you see on the screen, especially when it comes to our frail elders. This purposefully looks like spaghetti because that's how it generally works. As you can see, for the purposes of the recording here today, I've got the various transition possibilities between hospital, inpatient rehab, assisted living, nursing homes, hospice, and home, and the different permutations of those. So a care transition has many moving parts. Okay, the change of physical location is just the beginning. Consider, if you will, coordination of healthcare and social services, medical record updates, medication changes and reconciliation, instructions, next steps in care, new providers to educate, because that's what family caregivers do, paperwork, and all of that resulting in chaos for family caregivers. So elder care transitions are unique for several reasons. Any one of these challenges is tough to deal with. I've got a few of them listed here on the screen, but there are likely several of them playing a role in any given transition. For my family, dementia has always been the ever-present Mount Everest to climb whenever a care transition takes place. For my mom, the risk of more falls was ever present. So again, on the screen, for purposes of our recording here today, some of the unique aspects of elder care transitions: frail condition of the senior, dementia and mobility issues, medication volume and complexity, living situations that don't match care needs, fall risk, patient wishes versus family preferences, and all of this driven by what Medicare will cover or not cover. All right, so today our healthcare and social services systems make elder care transitions insanely difficult. The bulk of the work rests with family caregivers who are left to navigate the system on their own. We all know that story, and try to interpret complex medical terminology and insurance jargon along the way. And long-term care is still doing business on paper in 2017, as we all know is painful. So what does not happen today is communication, planning, collaboration, coordination, accountability, or training. That covers a lot of territory, and these things are not happening for us today. This results in a cascade of impacts on family caregivers. Now, we know these things to be our reality. We miss work. We go broke. We neglect our own health. And when all is said and done, there's actually a high likelihood that our parent is going to end up in the ER again, and another care transition is going to take place, and another after that, and another after that. So the big question is, what can the healthcare system do to change the current trajectory of care transitions? How about being a bridge? How about being a bridge? It doesn't take a lot of time to point a family to social services and supports they need. It doesn't take that much time. To provide clinical information in plain language. To help patients and families access their medical records electronically. Let's make care transitions a team sport. Now, Danny's going to share some of his own wisdom on care transitions.
So I have MS, and I've been a care partner for my grandmother, my mother, and a son on their end-of-life journey. And I've been a nurse for more than 40 years, and I've been a clinical and quality improvement leader for 25, and a patient caregiver activist for about 20. I review research funding requests for PCORI, the Patient-Centered Outcomes Research Institute, and I've been doing that since 2013. And most of that research does include caregivers. So I'm about 120. I look good, don't I? Okay, so I have experience with transitions and caregiving from many points of view. So, you know, I am a caree. I am a caregiver. You know, I am a nurse. I am a leader. So I've seen the process from many points of view. So when I first became conscious of this dilemma of transitions was when I was an emergency room nurse. And I would get the cases with the difficult families. And I relished them because to me it was just fun because, you know, you get to be a member of the family for a few minutes. And, you know, when somebody comes in the door and a disaster has happened and the disaster happens to the whole family, and when I partnered with the families, you know, I quickly found out what's going on, what are the meds, you know, what is the home situation like, what are they going to go home to, and by including the family in the emergency care, you know, then they would begin to know what were they going to be facing when they got home. You know, and I could talk while I'm taking care of them, so of their, you know, the person they brought in, and you know, they were more prepared, and all of a sudden, you know, it sort of dawned on me, you know, I was just doing this, but I began to understand, you know, what I enjoyed about it and why I was good at it, and so. One day I'm working in the emergency department and the ICU nurses come to see me and they say, we want you to be our manager. And I go, you guys are crazy. I've never worked in an ICU and I've never been a manager. And they said, look, we'll teach you the ICU, you'll be a fine manager. And I think part of the reason they did that is because I had a reputation in the emergency department. And so I decided, oh, what the heck, and I applied for the job and got it. And when I started, the first thing I wanted to do was to get rid of visiting hours. Like, it made no sense to me that families could come and see their person in the ICU for 3 hours a day. Like, what is that about? Well, I was really surprised when the staff, we didn't bring you in to do that. You know, we can't, you know, they're just going to be in the way, you know, whatever. I was really fortunate because the medical director was really supportive, and we eventually did away with visiting hours, and it's sort of the same idea that discharge planning starts the minute you put your hands on somebody. You know, here you are, now, where are you going? Where are you going next? You know, and again, it's the same sort of thing, working with the family, having the family work with you, taking care of their person, who's, you know, whether it's the ED or the ICU, and then they're, you know, by seeing what's really going on and learning to do some of the stuff. And, you know, as you guys know, families can do a ton. And, you know, I just couldn't see that, you know, it's like the day before you go home and all of a sudden, or an hour before you go home, you're going to do discharge planning. It, like, makes no sense at all. So I think that one of the reasons that this made sense to me is I had already been, you know, caregiver to my grandmother. And, you know, I could see, you know, what a disaster it was. And so it was like, you know, I had that experience and I was able to bring it in my role. But, you know, I'm also a caree. So I have MS, and I have secondary progressive MS, and the key word there is progressive. And, you know, I work very hard to progress as slowly as possible, but it's progressing. And I'm seeing how, you know, my wife and my family are, you know, I'm doing less, you know, I can manage less, and they're picking up the slack. And since we're a family who have been caregivers, you know, being a caregiver is not like a solo job, you know, to me anyway. You know, we did caregiving as a family, you know, and maybe I was the key person, the identified person, but it was a team effort. And you know, anyway. And so we, as I progressed, we have the same conversations that we've always had. What are we going to do when I progress more? What do I want? and I wanna stay home. I love my family. I love being home. I don't want to be in a hospital. I don't want to be in a facility. But my wife of 42 years, bless her ever-loving heart, is very clear to me. She hears me, but she makes no promises because, it's work. And we've always been, as a caregiving family, our health is first. We're no good to the person we're taking care of if we don't take care of ourselves. And so she's saying, I want to do that. And, it's going slowly so we can adjust, but makes no promises. She is not going to burn herself out taking care of me. And what can I say? It's something I love about her. It sort of breaks my heart, for myself, but I get it. And so we think about things like, there's stairs. I live on the first floor, but there's stairs. And it's an old place and the doorways are narrow. And, there's stuff that we can that we try to think about ahead of time. But you can't do it anyway. So, and we have a very strong social network. And we've been experienced in our caregiving lives, for my grandmother, my mother, and my son, of, how do you use your social network? And we're good at that. We're good at figuring that out. So that's something selfishly in my favor because we have a good social network, and hopefully my wife won't, it won't be on her and whatever, Anyway, so all I want to say is that I think, wearing all these hats and being able to see it from many points of view has been really good for me. And it's really made me realize, as Mary Ann said, most of healthcare is done by caregivers. It's not the doctors, it's not the nurses, it's not the hospital, it's not the clinic. It's home. It's the people who take care of people. So that's it. I say honor the caregivers, help the helpers. Anyway.
Okay. So I'm going to pick up where Danny left off. So I've spent a lot of time both as a caregiver and then, interestingly, while I was caring for my dad, I was working on products to help families and caregivers as they transition from hospital to home. I'm from a medical family, and I don't think that helps at all, really. We knew all the doctors, we knew everybody, and everything that I kept designing, I just felt like, well, my family could use this, and I kept looking back, seeing all the places where we missed key things in a transition. So, I think we talked about this a little bit, but people have their initial concerns. People are really scared to take people home. I think everybody here is familiar with these things. You're scared about the cost, about just being able to know what you're doing, about injuries. But I think the bigger problem is we don't know that we should be worried about things like social isolation, depression, family strife. It's great that it's worked out well for Danny's family and my own family. There have been great things where I got to know my sister-in-law, who's a physician, really quickly because we were working together on my dad's care. And meanwhile, my sister felt really left out, and she was way over in Denver not understanding what was going on. There are injuries to yourself. The employment issues, I think, are huge. At one point, I was really considering quitting my job until I realized my sister-in-law was still doing her residency. My sister's a social worker and was between jobs, and I might be the only gainfully employed person in my family at the moment. So maybe I should hang on to my job. And their own health. So I think that we're at a point where, we're not recognizing you have a known patient and you have a person who's now suddenly at risk for a whole host of issues: depression, injuries, abusing alcohol, and a million other things, also higher risk for strokes and heart attack. So these are the things that you can't really prepare people for, and we're doing a terrible job of getting out in front of this with them. So I think this is where technology tools can help, because it's very hard at the hospital to try and tell people. They were just there in the moment trying to be like, how do we get him home? I'm really scared. I probably shouldn't sit here and tell you about all the other things you should be really scared of that you don't even know about. But that's why I think getting to people at home is much better than in the clinic where your brain is swirling and you can't focus. So these are all the issues that have been pretty well documented, like I mentioned, the social isolation, loss of sleep, increased frailty for the family caregivers. And the other thing that we now know, and there's more and more evidence around this, is that including informal caregivers reduces risks for readmission. So even in the conversations I've had with some very highly regarded hospitals when I was doing my research for the care transitions products I was working on, they were saying, well, a lot of times there's nothing new wrong with the patient. The family caregiver just can't take it anymore. They don't know what to do, and they bring them back and they say, you take care of them. I'm overwhelmed and freaked out. So there's a lot we can do to also help the hospitals. It's kind of a win-win situation. So one of the products that's currently out there is really to help frail elderly. And this is something that can start in the hospital and then go home with the elderly patient. It's actually an avatar that's animated, and it's a combination of a real person and AI that's driving it. So it may seem strange that it's a dog or a cat. The person can choose what avatar they like, but it's actually nice that it's a pet and not a human. It takes away a lot of these other issues around like race and gender and like, are you relating to this thing? Whereas most seniors really, really like this. And they interact with it in a lot of ways. So this, they talk to it throughout the day at home. It asks them questions about, you know, did they take their medication? But it also gets to know them. Like, do they like to go fishing? What do they like to do? And it actually proactively talks to them about those things. So keep in mind, what's happening is they're interacting with it here. It's this audio video stream. It's understanding the text to speech. And around things like medications, it helps the real person on the back end respond quickly and appropriately, but it also really lets them personalize it and interact with the person in a much more warm and friendly way so that they really feel like they're getting to know them. And it helps them notice things like if the person's, you know, somehow starting to have cognitive issues or things like that, then they can report those things back to the family and the family caregivers. So what they're seeing with this is that it's helping with things like medication reconciliation, but it's also helping with things like self-management. It's reducing ER visits, which, as you can imagine, is just more chaos for the family member. It's reducing readmissions. It's improving satisfaction, and it's also helping to reduce things like falls in the hospital. So remember, they start using this in the hospital, and then they get to take it home with them. And it's a really resilient pad that they can take home. So it's not just like any old iPad, which are pretty resilient in themselves. But it's this care avatar, and part of what they're seeing is that they're also reducing these readmissions, which I think you'll also hear more about from Cathi, that we really see that hospitals are incentivized to give families and family caregivers these types of resources because it's also helping them better manage the patient and helping reduce that chaos where they're coming in and out of the hospital unnecessarily. So another one that's happening is something called resolution care, and these are palliative care consults that are done virtually. So the physician who created this resource, he's in Northern California, and he was literally taking small planes to fly out to visit some of his patients. They were in such remote areas. But a lot of palliative care, you don't need to do hands-on. So this is also great, though, for the family caregivers. So if you need to have a palliative consult, instead of tidying up your home and worrying about somebody coming over, you just show up on screen, and even if you're not in your parents' home, you can join and all have a conversation directly with the clinical team. And they're exploring other ways to support the families and really help them participate real time. But this is reducing home visits and a lot of that chaos of people coming in and out of your home while still really developing relationships. And I even got to sit in on some of these care consults. So one of his patients had just been was being admitted to the ER. She was in the ER, and they were trying to decide if she should go into the hospital and get some kind of pretty invasive treatment or go home. And he was able to talk to her virtually, even though we were at a conference, and have a conversation, and even pull in one of the family members to all have a conversation together so everybody knew what was going on. So you can really see how for the family caregiver, you're not just getting a call from your mom, oh, well, I went to the emergency room, but I'm just going home. And you'd be like, what? Does your doctor know you're doing this? So that's another great type of resource that's being developed. And then finally, there's interactive voice response phone calls. And these are things that are being scheduled for family care, for the patient and the family caregiver. So my mom, for example, could get daily calls or a call every other day. I could kind of choose the frequency and types of things I want to know. Do I want to know, is she drinking enough? Is she getting enough sleep? It could quickly ask her these questions and report those things back to me. So I now know, oh, she's kind of not eating as much, or I need to figure out how to help her drink more or get more sleep. So this is something that's also, again, being purchased by the hospitals, or in some cases employers, and then is being provided to the employee to help them care for their family member. So right now, this is being driven by AI, but there's a lot of planning that goes into what do you want to capture, what's helpful to the patient, what's annoying and not annoying to the patient. So there's a learning curve for this that everybody's kind of going through, but those are some of the resources available, and I'll turn it over to Cathi. Oh, this is the last thing I was going to mention, is that everybody's very interested in using technology, but the problem is that people don't feel that they have the time to learn what's out there and how to use it. So one of the things Cathi is going to talk about is how the hospitals are actually providing this to families.
Thanks, Geri. So as Geri said, I'm a nurse by background. My husband always jokes that I keep all my certifications up. When's the next time I'm putting in an IV or a PICC line? But I like to know what's going on from that perspective, because I was a nurse in acute settings, running a cardiac unit, an ED, at the bedside for years and years, right? So 25 years or so. I've been working at ME, now part of Welch's Clark, for the last over 12 years. So I moved over to the business side, thinking I knew exactly how businesses really help healthcare and really how healthcare ran. What I really found out is, as a nurse, we didn't understand how to communicate effectively with patients at all, or their families. Healthcare, like you already know, was really driven by sickness and illness, and you came there, they took care of you, you left. Now we're all living longer. We've got a lot of different kind of health conditions that can be managed, whether it's pediatric or adult. And we need to use the technology, as Geri just said. We need to leverage it in the same way that every other business is leveraging it, to help people be more effective and have more impact. And whether that's us as caregivers or care recipients or any of those that are providing care in today's world. So when I was a nurse in those acute settings, I was a little unlike Danny in one way. The hospital systems that I worked at, crazy busy, and it was probably all we could do. And when I think of a lot of my colleagues who are still in those settings, they have more check boxes today than ever before. So while technology has enabled us to do some things really well, as far as quality of care, there are more check boxes and less time even at the bedside. And while we know and believe that we're supposed to start discharge planning upon admission and work with families, we're so resource constrained, it's crazy. So when I look at this and you think, okay, let's focus on discharge, even if it's that somebody's being admitted to the hospital, we really need to think about how can we leverage technology to do that, because you may not have enough human resources to be able to do that kind of level of outreach. You may have the best of intentions, but the reality is the intentions on the hospital side came with exactly what Geri said, the reimbursement. So when there's value-based reimbursement and they're being reimbursed differently if they have readmissions, suddenly it's not just the right thing to do, as Danny was doing all along, breaking down the barriers and having patients at the bedside so they could learn. And even though we recognize everything Mary Ann said, which was all of these gaps that we had and no bridges, now it seemed like, okay, we really got to get on board because it's going to hit our balance sheet. So I'm going to give you a bit of a client story around this because it's exciting. They recognized the need, they knew they needed to do something, and they knew they also did not have enough people to do this level of outreach. So they were already buying into the idea that we're going to leverage both technology and people to continue to connect to our patients after they leave, to reinforce the things they needed to do for education and self-management and what to do next, to gather back the critical information that, as Geri said, they need to know to make sure that they can right the ship before somebody's going to come into the emergency room and you're starting that care transition all over again. So they knew that, but they went to their patient and family advisory council, and I applaud them because they said, hey, we put this in place so that we could hear from patients and families in our community. We're not really asking them if we're even asking the right questions. We have people doing this job today, and they're asking a bunch of questions. So they asked them, here's the questions we ask everyone, and guess what the feedback they got? Feedback they got was, well, it really sounds like you're asking us only about our experience, and it's about making sure your business is running well, not necessarily about our needs as a patient. You weren't really helping me. It didn't seem like it was about me, it was about you. Oh, wow, okay. That's kind of interesting to know, right? So they said, let's change that. And let's design this messaging so it should be about you, because that's really what it should be, because we want to partner with you more effectively. So not only did they design what the nurses were going to be saying at the bedside, and for any one of you, when my mom was in hospital and the nurse kept coming in, and every time she did, she said, what else could I do for you that would make your experience better? I would cringe. All I thought about was the HCAP scores they were trying to impact of their, how good do you feel about my, it's not a restaurant. It's more about, how are you today, Ann? How are things going, right? I mean, and so when you really hear it from your patients and family advisory council, and any of you that are on it, my whole thing is to have you go back and just empower them even more. That's really when it's not just about what we designed. But I think it's good as they incorporated it, and then they also heard from them enough to say, wait a minute, we want you to select and use tools that allow us to be involved as caregivers. My daughter who lives in California, even though we're in Florida, should be able to be involved in my care. You better find technology that allows that and kind of encourages that so they know how to participate. So that's exactly what they did. So what our solution does is it really designs and uses technology as a platform to be able to do that level of outreach. Now we designed it, make no mistake, the penalties were coming down harder on certain conditions more than others. Heart failure, AMI, pneumonia, COPD, then stroke, then orthopedics. They knew where they were going to get penalized more. But we continued to design disease-specific or general ones. We knew the basics were even broken. Nobody was making the follow-up appointment they didn't know they needed to. Nobody was reading their discharge instructions and taking it with them to the doctor. They thought the doctor they saw outside the hospital knew what was going on inside the hospital, and they didn't. So even those, picking up their medications, they want to make sure that if they did pick them up or didn't pick them up, and did they know how to take them well. As Geri said, that time right before their discharge, I got to tell you, I've been both the nurse and the caregiver for my family members. It's a very rushed time. You don't remember everything by any means. So in many ways, we're not teaching new information. We're reinforcing information that you heard and you received. We're doing it, though, with the human-centered design. And believe me, Geri was very involved. I've been involved on the roadmap of what we were designing. We use subject matter experts from 18 different facilities that were already current clients. But it was really our designers. And again, I'm going to really fault the idea that nurses and doctors know how to say this stuff. We don't. I'm on the advisory council for Purdue, nursing school I went to. Yeah, believe me, we still don't have a class in communication in the way we do on everything, how to use technology in your EMR. So how you talk to someone is how you're going to keep them engaged to want to pick up the phone again and again and again and make it feel like you've really heard them. So that empathy, understanding where they are, understanding they're dealing with a condition, and then helping them and guiding them along the way with that recovery. Normalizing things so that they don't feel like they're the only one that feels this way, right? They're coping possibly with a very chronic condition. It may not be some acute thing that they just had a total joint done, right? So understanding where they are and reducing some of that anxiety, but also understanding, what are those triggers? How do we motivate them a little bit more? How do we encourage them along the way that they're doing well or they're on the right track, or alert them to when they really need some help? This is about teaching them. It's not just about delivering back information to the care team. We do deliver back, though, what the patient says. Patient-recorded outcomes, when I went to IHI and presented one of our clients' results back about 4 or 5 years ago, people pooed the idea of patient-reported outcomes. It was all what's provider-driven, right? Completely. No one believed it. You go there now and they're like, oh my goodness, what the patient said, that's the most meaningful. You could have somebody with the exact same clinical outcomes. If they feel good about things. I was a cardiac nurse. My dad had an ejection fraction of 11. He should have been hospitalized, never was. He felt like good about where he was. I don't know, was that hormones keeping him going? What was it, right? So we got to believe that what the patient says is what's very much the most important thing. So learning from them is what you want to do. Along the way, though, now a lot of these solutions that are out there, and lots of good ones, and they're all really trying to do something, as far as connecting to the patient. We take a two-prong approach, though. I'm a three-prong. One, we don't believe it's just interactive calls of giving you some information and gathering back some information, reporting it back. We also believe that you need to be educated along the way. Continue to educate along the way. Because that positive reinforcement of how to build upon that education is going to empower you as a patient. So it's that two-pronged, and then the third, I'm going to say that third seat of the stool is getting the family involved. So I'm using here, you can kind of see that you're teaching a heart failure patient what it is they need to do along the way. What they might think about sodium might be very different than what you thought.
For people with heart failure, it's very important for them to see their primary care doctor for a follow-up appointment that very...
Okay. That should have been this. So you're going to hear the voice, this empathic voice, just giving an idea of what to do. Maybe.
But to catch this kind of small weight gain, you have to weigh yourself every single morning. Start with a good, reliable bathroom scale. And use the same scale every day. Make sure it's on a flat, level surface. You don't want it to wobble. Your scale should also be clear and easy to read. You should be able to read the numbers without bending over or moving, because this can change the reading. You also need a calendar or a journal so you can write down your weight. So tape a calendar to the wall or keep a small book in the bathroom where you can write it down. But do not rely on your memory. Okay, always weigh yourself with little or no clothes on. After all, you don't want something you're wearing to throw off your weight. And weigh yourself at the same time every day. The best time is first thing in the morning after you go to the bathroom and before you have anything to eat or drink. So just get up, go to the bathroom, weigh yourself, and write it down. And if you have any problems with your legs and need help standing, or if you're in a wheelchair, ask your doctor about the best way to weigh yourself. But to catch...
So I'm going to end with this. I think one thing you could see there is we're trying to do what Marianne said, where it's simple language. Doctors and nurses, we talk in this foreign language, and we don't think we do. We use a lot of terms. I still do it with my own family. And they'll be like, okay, again, we have no idea what you're talking about, right? So what they're doing there is putting in simple language, kind of those very simple steps in plain language of what to do. You're trying to empower somebody. Now, from the results of that, our clients found that heart failure patients, and again, I was a cardiac nurse, they're going home, they know they're supposed to weigh themselves. They know they're supposed to weigh themselves. The study at UAB showed 59% of them weighed themselves on day 1. On day 14, 89%. On day 45, 93%. Any one of us that starts anew, I'm going to eat better, I'm going to exercise better, it doesn't happen in a day. It takes time. You need to teach somebody. Nothing better than to help you as caregivers, if you're a caregiver in the audience, or the provider, slowly teach someone and have that family member who reminds them, who heard those same messages, hey, Dad, are you weighing yourself every day? Same time and all of that. How's that going? to empower them to be successful. I would challenge each of you to go back, if you're on a patient family advisor, if you're working, if you have a business here that's involved with hospitals, health systems that have patient family advisory, they should be vetting all of the products in use, right? They should be thinking about whatever tools that Geri talked about, I talked about, Marianne might know, Danny might know. How do we make sure we're really enabling with the technology tools we use every single day ourselves for the rest of our lives, or every other kind of gap? Is there people and resources or strategies? How can we improve that? So we want to kind of take the next 20 minutes we have and encourage some stories from any of you, either on where you want to ask any one of us a question about what we're doing and how we're, kind of improving maybe some of those different care transitions, or also tell your own story and maybe even a tool or things that you're seeing that might be helpful. Or you could share a story where you see a disaster and we could all brainstorm on how that might be turned around. Is that a good?
Yeah. So, I'll start by asking you guys, and we have this mic that people can use. We want to know what your challenges are as you go from hospital to home. So asking Marianne and Danny, but also any of you, if you've had specific challenges that have come up.
I was just going to echo some of the things that you guys mentioned earlier, like the information doesn't follow you. So I'd be interested in the sort of professional perspective on what prevents that from is it administrative policy? Are there regulations? What prevents the records from transferring easily between, aside from the facilities that are just using paper? I mean, I'm talking about like hospital to hospital, they both have electronic records. What prevents that? Because it's just, why am I the conduit for all this information? That's kind of one of the questions.
Do you guys want to take some of that? I know part of the problem is interoperability, that the systems don't all talk to each other. So I know there's like HL7 and some of these things where you have to have those in place, but even when somebody comes into the ER transferred from another hospital, they're often printing off tons of records and then scanning them back in, and that's one of the problems. Do you guys want to speak to any of the other issues?
I think it's never been like a major focus. Like we know transitions are everywhere all the time. Like you'd think that since it happens so much to everybody that it would be a priority. Well, it really isn't, because people are operating in their silo and they're trying to do a really good job in the world that they know, and they forget. And the systems that are developed, meaning so the information systems, as Geri said, they're not really designed to share information. There's a movement towards that, but there's tremendous barriers, and it's really not yet in anybody's financial interest to make that happen. And so I would agree. I live in Boston. I see, 7 specialists in 3 different systems, and I make use of the portal. Damn it, I am still the guy who's bringing my record from place to place. It drives me crazy.
We actually have a friend in the patient advocacy community who tattooed a QR code on her chest. I'm not kidding. She really did this. Yeah. And she put together her own medical record. She's had cancer, I think, a couple of times and many other issues. And she was so tired of trying to send people to one place to see her information that she's like, just scan me. Like, it's that bad that people will go that far. So, any other? It's the most exercise I'll get all day.
Hey guys, so I'm a researcher, and one of the studies that I was doing was around supporting family caregivers in the post-acute setting. And so I was super curious on what you've seen to really get some of those post-acute care providers to buy in to supporting caregivers. I just had a vivid moment that I remember where one of our study participants was on the Patient Family Advisory Council for this home care, like post-acute care provider, and was giving us in our study a lot of great feedback on like the support that they needed. And when we kind of brought that to that organization, they were just like, yeah, but like, you know, our families are very well supported. Like we do exactly what we need to do. And so, and this was, as you said, you know, people had the like pay the PFAC, they care about their quality improvements. And so it's like, what's the next step? Like, you know, like if all things are perfect and they're still not, you know, buying in, what's the next thing that people can do to advocate for supporting the family?
So I'll take that as far as, unfortunately, kind of like Danny just said about the interoperability and where it's coming to become better because of alignment of reimbursement, right? That kind of financial is what drives everything. So the post-acute settings are going to be the last to kind of see this shoe drop, right? So now that they are going to be penalized for things like readmissions, hate to say it, but they're even more resource constrained than the hospitals. So they're now really worried, and they want to step up to the plate. One of the things I didn't mention that that our solution does. So yeah, you want to do the self-teaching, and we've been able to demonstrate that. You want to reduce the readmissions. But the one thing that I think can also help improve is you don't know what you don't know. You don't know how your discharge process is really going. You think you know. Well, our data for everybody that's talking back into that phone is sliced and diced into little areas that give them an idea of how many people are really depressed. So is there a behavioral need? Is there a resource need? So depression is huge, but nobody was thinking that was their issue, right? So understanding where you're falling down is the first way that you can improve it. And that data is not going to lie to them. So now they can kind of pinpoint with a laser and say, what are we going to improve of what we already have? We already have those people, so we can improve that process. And where can we enlist and get some other resources? That's where I think they will start using the people that have said they want to be involved, their family members, to come in, support groups and things like that they can design. A couple of our clients have put in support groups in areas they never thought they needed them at all. Didn't know it at all. Medications that everybody thought they were filling, but they weren't, because they didn't want to tell the nurse or doctor they didn't fill them. That would disappoint them. So not knowing that information didn't let them make changes they could have easily switched in their formulary. So I think this will be the same as true for the skilled nursing and all of those post-acute because of this reimbursement alignment.
And I will add to that too, that until post-acute figures out that they need to partner with adult daughters who are the glue that is holding this all together right now, then things will start to change. When they start viewing us as partners in care, we know what's broken, and we kind of know how to fix it too. So use us as a resource.
Well, and the last piece I'll add to both of those is, you know, they struggle with having a lot of fights and challenges with the family. You know, one of the things I've heard in working with post-acute is like, well, we're trying to keep the heart failure patient on a low sodium diet, but their family member comes in here and brings them their favorite food. Well, the family member doesn't understand why they need to be off salt. So like, if you could help engage the family care member in understanding why do they need to be on a low sodium diet? What is that doing to their heart? Why are you even sending them home with water pills? You know, I've had people say, oh, we stopped giving those to him. They were just making him pee. It's like, right, that's what they're supposed to do. But the family members don't know that. So, you know, if they want to see less frustration with the families who they feel like they're fighting with and tug of war, this could be a benefit to them to have much better relationships and much less stress in their setting as well. So,
Geri, I want to add one thing, just listening to Marianne, and this is the first day I've been at the conference. I wasn't here yesterday, but I talked to 4 or 5 people just having lunch or in between sessions, and it's interesting to me because the caregiver, it sounds like, is oftentimes a female. Not to go into a women's movement moment here, but I would say from when I'm talking about the PFAC and Patient and Family Advisory, maybe every woman in here and every guy in here should invite more males to join these. One, I think my personality is like that, which is like, let's get this done, let's change this. So we need advocacy at lobbying and everything else. And some of these people that might have that business hat that they want to put on can help make some changes that we need to have happen. And I don't want to call it demanding, but I think there's an opportunity there when we have as many men as women caregiving. There's an opportunity for us to learn from each other and really build on those skill sets that we might all have.
So with the last time we have left, were you going to add to that, or?
Nope.
Okay. We wanted to ask if anybody's had any positive experiences, resources, things that help them during a care transition, especially from hospital to home. And I don't know if you guys also want to weigh in on anything that's especially been helpful to you during a care transition.
Before I jump into the positives, I just wanted to ask the panel if there's any relationship to the admission criteria. My aunt was 89 years old, and she could understand you perfectly fine, and she had her full mental capacity. They did dementia test after dementia test, and she passed them all. But when they did the hospital follow-up calls, they never noted that she doesn't understand on the phone, nor can she respond. And it really upset her, and in turn started to really upset me as the caregiver. Is there any, coordination between that when you set up these calls? Just curious about that. I am familiar with Emmy from Loyola, but we never got a benefit from it, I have to tell you. So I'm just wondering.
Well, you're not using it. I mean,
well, they did in our patient education, like Emmy videos in cancer care.
You've not been a client of ours, although we would love you to be a client of ours. But I would say, as far as this goes, so I don't know exactly what is she hard of hearing?
Yeah, she's deceased now, but that was my dilemma.
Yeah. So one of the virtues of this is that the nurse, the doctor, the care team is supposed to introduce it, should be talking to the patient about it. And so your aunt at that time, or her caregivers, that could be the neighbor that helps her, it could be the son or the daughter, it doesn't have to. They can elect to have them actually be the ones that are giving some of those answers and understanding what she's supposed to do. Someone else that also cares about it. Now, we do have some of these where, say for stroke, where we're saying to them that you can answer by pushing a button, or you can say it in the phone. Now, if she can't hear, that's not going to help in that way, right? She's not going to be able to hear it. In that case, you do even more so, no matter what was happening, if it was a person or an interactive call, you want to make sure that you have somebody else that really wants to get those calls, and they can indicate that right then and there, up to 4 different care members, so that they really do have that backstop, if you will, to kind of pick up the phone, be the one that was indicated, go ahead and listen, and also go ahead and give those answers. For your aunt, I would still say the educational programs would be beneficial, because again, she can see the text, have closed caption on even at home, anywhere you can get on the internet, simple, intuitive, and it's that animation. And that still makes her feel empowered. It's still her body, and as you said, her mind is there. Just because you can't hear doesn't mean you don't want to understand, right? So I think it's those 2 things.
Oh, no, that's okay. I was just realizing we're pretty much at time, but I didn't know if you still wanted, if you had also a positive experience. Okay. So did anybody else? I know Marianne had to leave for her other panel.
We've got about 4 or 5 minutes, but she's got to get ready for the next session.
Right. So, Danny, is there anything that you've experienced that was especially helpful during a care transition?
I just think the staff that cared and put themselves out and got in touch with us, and that made the difference. I mean, it's the human touch, it's the human contact, it's the human availability. That's it.
Okay, well, we should probably wrap up unless anybody has, oh, we have a last question. Sorry, I didn't see you back there.
When my dad got out of the hospital, the VNA were fabulous. They came in, and the fact that they can rotate like a nutrition person and a social worker and come in and help you find resources was incredibly helpful. Dad had congestive heart failure, and so in trying to help him, we were using spices that were not helping his GERD. And I was like, you're kidding, pepper's the worst thing? So that nutritionist gave us insight, which was really invaluable. And the fact that they came to home and I could hear it and Mom could hear it was incredible. We didn't really have any interaction at the hospital once he left. It was completely the VNA.
Thank you.
Okay, any last comments? Otherwise, I think we should wrap up so people can go to the next session. Okay, thank you.